Hey, good morning, everyone. Welcome to a really early morning program here at American Heart. I'm Scott Wright from Mayo Clinic. I'm joined by my illustrious colleague, Peter Jones from Baylor. Peter, good morning. Thanks for
Good
coming.
morning. My pleasure to be here. Thank you.
Yeah. Thanks to all of you for braving the early morning to come out here the last day of the American Heart. We have a great program for you on personalizing the management of hyperlipidemia. We want to thank the university and its peer review process for providing this, to Novartis for sponsoring this educational grant to peer review. And if you haven't already, please complete the pre-event survey. And look up for additional follow-up polling. During the presentation, we'll be asking you. You should have some devices that are white right in front of you on the table that you can answer the questions. And if you have questions, please submit them. They're going to be actually the old-fashioned way, down on pencil and paper that you have, and they'll be collected and brought up to the stage. You can download the slides and other things at this website that's listed here on the screen. So please feel free to do that. We've made these slides for you to use and to share in your practices and in your community. All right. So our first question this morning is a demographic polling question. The results will not be shown, but please select your degree or certification. Any of the choices are fine. Just pick one, though. So our apologies to the MD PhDs. All right. Now, if you are a physician or really a healthcare provider, please indicate your specialty, please. Thank you. If I could ask you, please, in the care of approximately how many patients with high risk or very high risk hyperlipidemia are you seeing each week in your practice? Is it none, 1 to 10, or any of the choices there? Or if you don't do medical practice, you can choose number 8. So please let us know. All right, thank you. And which of the following practice settings is applicable to you? You have 4 choices here. All right, thank you. Now we have a baseline polling question. This is in part based on the recent publication in JACC from September. On the new consensus statement. So what risk classification would you assign to a 44-year-old woman, let's call her Ann, who has a history of TIA and hypertension with a BMI of 27, a blood pressure of 122/77. Uh-oh, what's happening to the slides there? Can we go back? There we are, all right. And LDL of 200 and an unclear family history of CVD or FH. Would it be very high risk, intermediate/moderate, low risk, or you're not sure? All right. Now, question number 2. The same individual with an LDL of 200, intolerant to statins, is currently treated with icosapent ethyl, losartan/hydrochlorothiazide, and aspirin every day. To improve her hyperlipidemia management, what would your next step be? Would you initiate bempedoic acid, a low-dose statin to try her again, ezetimibe, a PCSK9 targeting therapy, or would you say that she's pretty well controlled with her lipids with her current risk status? So please vote. All right, now we're going to give you a second case. This is a 74-year-old gentleman who has a history of type 2 diabetes, has developed neuropathy, so an end complication of the diabetes, prior history of myocardial infarction, has a history of a percutaneous coronary revascularization, is also suffering with heart failure, you could imagine, and is NYHA class 3, has significant renal dysfunction, CKD stage G3, or hypertension, and non-alcoholic fatty liver disease. And if that isn't enough, his LDL is 170, despite being on metoprolol, hydrochlorothiazide, Entresto, finerenone, metformin, empagliflozin, clopidogrel, aspirin, furosemide, atorvastatin, and ezetimibe. Well, he's got a fourth meal a day in his meds, what you say?
That's right.
To improve his dyslipidemia management, what would be your next step? Would you treat him with a PCSK9 drug, and if so, which one of the three? Or would you say, not for me, I'm sending him to Dr. Jones, a lipid expert? Or would you say he's pretty well controlled? That's about as good as it's going to get, and let's not worry about it anymore. How would you treat this patient? Presumably, this patient has good insurance.
I hope so.
Take all these medicines. All right. Well, thank you. Let me move my picture off this thing there. So, all right. Well, I'm going to begin with just a few background slides and then turn this over to Dr. Jones to do our first practicum. What we can know over the last 20 years has been that cholesterol management has improved in the United States, but not to the point of perfection, right? We're still seeing most patients in our practices who have significant elevations of all of the lipoproteins, whether it's total cholesterol, LDL, or even triglycerides. And HDL is reasonably well controlled, but that's more of a population thing than anything. You can see that women have higher HDL values than men. But surprisingly, women also have LDLs that are higher than men. So still a long way to go to treat dyslipidemia adequately, especially given the new consensus statement out about what's an optimal LDL level. And what we know is that mortality rates in patients who are on treatment for secondary prevention often mirror the intensity of the LDL lowering. Now, it's much easier to get the intensity of treatment by the intensity of the statin, right? Because that's available with all kinds of electronic records, whereas lab values are much harder to define. So if we look at patients who get high-intensity statins, if we look at men or women, you can see that among all of the groups receiving treatment for dyslipidemia, those who have a high-intensity statin have much lower mortality compared to those who are either not treated with a statin or those who are on low-intensity statins, right? If you're on a moderate-intensity statin, you sort of do in between the first group, which is high-intensity treatment, and the second pairing, which is sort of no statin versus a low-intensity statin, where there's not much of a difference. And this really hasn't changed over the last 20 years, that the statin, the degree of LDL lowering really determines the reduction in events and the outcomes. And the same is true for women if we look. Women may get a little benefit from low-intensity statin compared to men, but those who are treated with the high-intensity statins do the best. I think what we can see is that we really still undertreat most patients who have dyslipidemia because mortality rates remain too high. It might surprise you to learn that only 80% of patients in a large U.S. registry called Pinnacle were given a statin after an acute coronary syndrome. And it probably wouldn't surprise you that about half of those stopped the statin by the first year out in their follow-up appointments. And there's a large variation in clinical practice. Some practices actually had nobody getting started on a lipid-lowering drug or a statin, and others were using it, a small percent were using it 100% of the time. The same is true for patients who have FH, and FH is one of those really lethal conditions, especially if you have homozygous FH. It's underdiagnosed, and in fact, most of us in the room who are either cardiologists or other healthcare providers have trouble diagnosing heterozygous FH. And about a third of cardiologists and over half of all primary care providers have never prescribed the therapies really targeted for FH, and that is the PCSK9 class of agents. So even in patients with FH, there's inadequate treatment of elevated LDL cholesterol. Why is it so hard to treat patients for dyslipidemia? Well, I think prescribers genuinely have a challenge risk stratifying patients. It's not convenient or easy to pull up a website and put your patient's demographics in and come up with a 10 or 20 or 30-year risk score, is it? Unless your electronic record does it for you. There's also uncertainty about the benefit in certain patient groups, right? I get a lot of pushback from general internist Dr. Jones. You might be surprised at this, because I keep patients over 80 on statins. And the question is that ethical? And I say, what do you mean, is it ethical? It reduces the risk of stroke. And they're like, well, yeah, but you're going to keep them alive forever. Yeah, well, I guess that might be the goal. There's also discrepancies among the guidelines, right? I mean, the medical communities have to have a little controversy, so we just publish guidelines and we disagree with one another. It's also clinical inertia. It's how many issues and how many things can you juggle at once, right? I mean, someone like me who has talked about lipids for his entire career has trouble sometimes getting everyone treated because patients come in and you're dealing with their life-threatening issues and their other issues and dealing with some of their social issues, and then the lipids get forgot about because they're here to talk about aortic stenosis or something, but we shouldn't be forgetting about it. It's not clear if you're a specialist like me if you should be doing it or if you should send them back to the primary care provider. I teach our fellows all the time not to burden the primary care providers, to just get the patient started, because when they come to us, it's expected that we do it. And of course, with economics the way they are in healthcare, there's just limited time to discuss. There's also patient factors. Patients read a lot now. Every time I prescribe a statin, patients are now pushing back. What are the side effects? Am I likely to get myalgias and problems like that? Patients also overestimate their vitality and underestimate their personal risks of a recurrent cardiovascular event. I like to say that among all species, we humans are the best at self-denial, right? We just ignore our own health issues and our own issues to a great extent. And I think a couple of iterations ago, the guidelines went away from targeting LDL values. Thankfully, they're back now, but because of that, cholesterol is measured less, and so people just really don't know what their cholesterol values are. If you ask a patient today, what was your last cholesterol? They can't remember. 10 years ago, it was different. They really knew that. And sometimes they're just unaware of why the medicines are prescribed. They just trust us to do it. All right, well, let's turn it over to Dr. Jones now, who's going to talk about some unmet needs in managing dyslipidemia. Peter?
Scott, thank you very much. It's really a pleasure to be here, and thank you for coming. It's great to see some familiar faces in the audience, and I haven't seen in the last couple of years. It's nice to be back in person. Yeah, my job is to sort of set up what's coming next with Scott's lecture, but I'd like to address some of these unmet needs. And we're going to start with actually the patient that you were asked the question about, which is Anne, who's a 44-year-old woman of European and South Asian descent. You see over here you're seeing her for the first time, so you're getting this history on her. So she had a TIA 3 years ago, and it was at a time when her blood pressure was high and it was not adequately treated, but now it is reasonable. But her LDL is 200, and the family history of coronary heart disease or cardiovascular disease, or whether there's FH in the family or whether she has FH, is unclear. And her current medications, amazingly, she's taking icosapent ethyl, but only 1 gram a day, losartan HCT, and aspirin. And the problem is, and the reason her LDL is still 200, and probably why her doctor sort of gave her this IPE, is because she says she's statin intolerant. She really had a difficult time. The doctor told her she needed to take high-intensity statin, rosuvastatin 40, and she couldn't tolerate it. Well, apparently that was that. And so here she shows up in your office. You ask her about this LDL of 200, and she said, well, yeah, he sort of said there might be a genetic reason for that, and all, but nothing was really followed up and done. Okay? So that's where we are with Anne. So the question is, is she high risk? Is she even more than that, or very high risk? Well, in 2018, as you know, the AHA-ACC cholesterol guidelines sort of said who is high risk for future cardiovascular disease event. Well, of course, it's anybody who has a personal history of cardiovascular disease, whether that be ACS, MI, ischemic stroke, TIA, PAD, or a history of an intervention like a bypass or a PCI. Of course, it could be, any patient who has a genetic reason for a high LDL over 190. Okay, so you consider them heterozygote FH. And then, of course, you can, depending on whether they're pooled cohort equation, if their primary prevention over 40 years old, if the pooled cohort equation score is greater than 20%, they would be considered at high risk for a future cardiovascular disease event. So obviously our patient sort of tends to fit in 1 and 2, most likely for high risk of a future event. See if I can get it to move to the next. There we go. And of course, the 2018 guidelines helped us a little bit in defining high risk and even very high risk, and some guidelines have even gone to the extreme risk by looking at enhanced risk factors. So these are things that, in addition to the way we just described them as having established cardiovascular disease or FH, they have a family history of premature cardiovascular disease. They don't necessarily have to have FH, but they can have a polygenic cause for their hypercholesterolemia, 160 to 190. They have the metabolic syndrome. We all know what that is. They got to have 3 out of 5 of the characteristics of increased waist circumference, triglycerides more than 150, elevated blood pressure, high glucose, or a low HDL less than 40 in men or less than 50 in women. CKD, that would be an EGFR between 15 and 60. Chronic inflammatory conditions, of course, psoriasis, rheumatoid arthritis, lupus, inflammatory bowel disease, HIV are all considered chronic inflammatory conditions. For women, important would be premature menopause or any pregnancy-related problem, such as eclampsia, preeclampsia, or gestational diabetes. And last, there are some high-risk ethnicities, of which, and a highlight here is South Asian ancestry. So if you have one or more of these enhancing risk factors, it moves you along the risk category. It shifts you up along the risk categories. I think all of you are familiar with that. So as we look at Anne, this is the polling question. Again, she's 44. She has this history of TIA and hypertension and this LDL cholesterol of 200 and an unclear family history of either cardiovascular disease or her personal history of FH. What do you consider her to be? 1, very high risk, 2, high risk, 3, intermediate, 4, low risk, or you need more information? We'll see if this changes what your original decisions were. Well, of course, if you take a look at the 2018 HACC guidelines, the risk scoring is the pooled cohort equation. You use that primarily for your primary prevention patients. Based on your scoring and your situation and the risk of the patient, there were LDL goals that were set up, or thresholds that you were trying to accomplish. Most of it for moderate risk or high risk was based on the intensity of the statin. You were trying to give the appropriate intensity of statin to lower your LDL cholesterol at least 30 to 50% if you were moderate primary prevention risk, high risk more than 50% from baseline. And if you were very high risk, you were supposed to get below the threshold of 70 milligrams per deciliter on LDL or less than 100 on non-HDL. The therapies were supposed to be evidence-based, and that would be statins, ezetimibe, and the PCSK9 monoclonal antibodies. The therapies that were not really discussed because the guidelines didn't have them available at the time would be bempedoic acid and the small interfering RNA to PCSK9 and glycerin. They didn't really discuss either the drugs that are orphan drugs for homozygote FH, which were lomidopide or evanicumab. Of course, the ESC has their own, EAS have their own guidelines that came out a year later. Their risk scoring uses the SCORE, which is not really a composite of fatal and non-fatal events. It's primarily fatal cardiovascular disease. I think the ESC and the EAS just recently came up with a different scoring thing. It's called SCORE-D, which does include non-fatal cardiovascular events. But they're much more specific about their LDL goals, not necessarily just trying to achieve a reduction from baseline of at least 50% in high and very high risk. They were very specific in thresholds of getting less than 70 if you're high risk and less than 55 milligrams per deciliter in LDL if you're very high risk. Again, they also discussed the evidence-based drugs, statins, ezetimibe, and PCSK9 inhibitors. And again, they did very little to discuss some of the therapies that were not available at the time. They did discuss some of the future therapies. Let's see if I can get it to move. Now, look at it, and this was just, Scott mentioned this, I think you saw a couple of months ago, the ACC came out with their expert consensus decision pathway, and this was to help you use non-statin drugs to achieve optimal LDL cholesterol levels. And the treatment algorithms were still based on the groups that the ACC-AHA came up with in primary prevention and secondary prevention. So your primary prevention patients are obviously those that would be considered for additional non-statin drug would be those with FH or severe hypercholesterolemia, LDLs more than 190. Could be adults with diabetes with LDLs less than 190, and it could be if your risk status was high enough, potentially primary prevention without diabetes, but LDLs between 70 and 190. Of course, the secondary prevention, they did describe patients who could be high risk and not high risk with established cardiovascular disease. And particularly in relationship to Anne, it would be those who are very high risk and potentially have FH, and those who are not very high risk but do have an LDL still above 190 milligrams per deciliter. So though the expert consensus decision pathway was based on the information that we know that's beneficial for reducing cardiovascular disease, not just LDL cholesterol, but cardiovascular disease. And when you look at this, obviously lifestyle risk factor control is important, weight reduction, physical activity, appropriate diet, pattern, smoking cessation. Statins are clearly indicated by clinical trials, ezetimibe and PCSK9 monoclonal antibodies. Specialty medications, which don't have a lot of outcomes yet, and we'll talk about what those are non-statin drugs that can lower LDL cholesterol, but don't necessarily have the outcomes that the other three drugs are there. And then finally, there never will be an outcomes trial with apheresis, but it is an option for some patients. But there is plenty of data to suggest that in patients treated with apheresis compared to controls that are not, there are much better outcomes lowering lipids, whether it be Lp(a) or LDL cholesterol, by using LDL apheresis. So in the expert consensus decision pathway, obviously as complicated as it can be, and hopefully most of you have seen this, and I'm not going to read everything to you, but the question is, in patients who are like Anne, who have ASCVD and an LDL more than 190, the question is, if I can get this to show up, do they have a statin? Did they get greater than high-intensity statin? Did they get greater than 50% lowering in their LDL? And is their LDL less than 70 milligrams per deciliter? If the answer is yes, then you move all the way down to the bottom and you go just adhere, stay with it, and follow them. Well, of course, Anne is not that. She couldn't tolerate a statin, so it goes to no. What do you do next? Well, maximize lifestyle therapy. Consider what you do in managing statin-associated side effects, which for most patients is called SAMs, statin-associated muscle symptoms. And then you consider how you can or change statin therapy, and we'll talk about that. If they're on moderate intensity, they need to go to high-intensity statin to see if you can get more than 50% lowering or less than 70 on LDL. If you're still no, then you start considering what are your add-on non-statin drugs. And based on the clinical evidence, they have 3 steps to consider here, which would be consider adding ezetimibe first, or a PCSK9, or both. The next would be, because of the evidence base, then the next would be consider bempedoic acid alone, could be the fixed dose combination with ezetimibe, or inclisiran. And then your last third choice, depending on the situation, why their LDL is above 190, particularly if you think it's a compound heterozygote or a homozygote, would be to consider apheresis under the care of a lipid specialist. And then, of course, did you, with all of that, add on, did you get less than 70? Then the answer is yes, then you continue them on with therapy. If the answer is no, then you definitely need to refer them to a lipid specialist because probably they may need to consider the possibility of other therapies, including apheresis. And here's an example of what Anne would probably fit in. And this is looking at patients between LDLs between 100 and 200, adding on evidence-based treatments from what we've learned over the past 30 years. Using statins alone, most of it was moderate intensity statins, you could move this group from 100 to 200 down. Okay, so you get 30%, 40% lowering in LDL. Then we came to the point of high intensity versus moderate or low intensity statin. We had outcomes in that, so it proves that yes, you can move the bar a little bit more, lower the LDL, and you get better outcomes. Then you add ezetimibe, you can further lower it. Now you're starting to see that this group's getting down to sort of reasonable LDLs in this range. And then finally with evolocumab and alirocumab with the PCSK9 monoclonal antibody outcome data, if you added that on, finally you could get all of these patients to LDLs below 50 milligrams per deciliter. So this is the evidence-based approach to managing this. So this will be discussed a little bit more by Scott, but just want to show you again oral medications that we have. We have statins, obviously up to 60% at high-intensity statins. As single drugs, ezetimibe 20%, bempedoic acid about 20%. The fixed-dose combination of the two, by the way, can get you close to 40% lowering in LDL. Icosapent ethyl, which is approved to use to reduce cardiovascular events in patients who are high risk, very high risk, doesn't really lower LDL much. At best, you might get 5%. The injectable medications, of course, the monoclonal antibodies can give you 50 to 60% lowering in LDL, evolocumab and alirocumab. Of course, inclisiran, which was improved as a small interfering RNA against PCSK9, can also lower it 50 to 60%. Then as you look at what the expert consensus decision pathway would show you, going with ezetimibe and a statin, 65%, statin plus PCSK9, 75%, and if you were to use all three, you can get an 85% reduction in LDL from baseline, which for a lot of patients could get them below 70 certainly, and for some even below 55 milligrams per deciliter. Let me just tell you that the question about using combination therapies is for patients who may have difficulty tolerating statins. And this is an example of somebody with a moderate intensity statin plus ezetimibe is actually more effective and better tolerated than high intensity statin. So this was a study out of South Korea looking at 3-point MACE over 3 years. And actually the combination group of a moderate intensity statin plus ezetimibe actually had lower event rates than those who were just in high intensity statin alone. The LDL was less than 70 in more patients with that combination of ezetimibe and moderate intensity than high intensity statin, and that the discontinuation rate was lower. Probably better tolerated for most of the patients with moderate intensity statin than high intensity statin. So keeping that in mind, we used to have a fixed dose combination of a statin and ezetimibe. Most of you may have remembered that, called Vytorin. Given as one tablet is actually, not surprising to you, associated with better adherence, and as a result, lower cardiovascular disease event rates. And this was a study that came out of the Lombardy region of Italy. So actually, the patients who took the fixed dose combination tended to tolerate the medication better. They were more adherent, and probably therefore their LDL was lower more time than the other group. And so the single tablet therapy is obviously a pretty good option. But unfortunately, we don't have that fixed dose combination available to us, but it is important. Our patient has statin-associated side effects, and for her it's muscle, which is the most common. So the question is, what are you supposed to do with this? Well, the expert consensus decision pathway tells us, try to do the best you can in working with these patients, although there's extremely rare cases of rhabdomyolysis or even autoimmune rhabdo associated with statin use. Most of the patients just have the muscle-associated side effects. And what they tell you to do is really try to use more than one statin, which Anne apparently tried high-intensity statin and stopped and nothing else was done. Try at least 2 or more statins. Try them at lower doses. And, even try different dosing schedules. Monday, Wednesday, Friday, once a week. Those kind of things are all potentially options that you can do. By the way, it is amazing how the patients, and this is something you probably all know about the nocebo effect, but telling them that you can give them a statin that's not 40 milligrams, not 10 milligrams, not 5 milligrams, but there is a statin out there that's 1 and 2 milligrams called pitavastatin. It's amazing how suddenly they seem to do okay with 2 milligrams of a statin. They couldn't tolerate 5 or 10 or whatever. So it's amazing how that sort of works out. But the bottom line is, depending on the patient's risk status, with statin-associated muscle symptoms, whatever statin they can tolerate, even if the maximally tolerated is 0, then you've got your high-risk groups listed here. And what you do is consider ezetimibe, PCSK9, you can do bempedoic acid or inclisiran, or if they're homozygote FH, the orphan drug indication for evolocumab, that's at the top. But most of these are going to end up being ezetimibe or PCSK9 inhibitors with the possibility of using bempedoic acid alone or in combination, a fixed dose combination with ezetimibe, as you move through these risk categories for statin-associated muscle symptoms. I'll just tell you that don't want to go through this too much, don't have a lot of time, but I think most of you know in trials of N of 1, we've sort of come up with this idea of the nocebo effect. The Sampson and the statin-wise trials tend to show that patients who've had a history of statin intolerance, that if you give them placebo-controlled trials of statins and rotate them between statin and placebo, and they don't know what they're taking, they end up similarly having the same number of side effects on the placebo as they do taking the statin. There was even one trial where they actually gave note therapy. So one of the trials was an empty bottle for a month. So they gave a statin, placebo, and an empty bottle. They didn't know the statin or placebo, they didn't know the empty bottle. And interestingly, some patients had symptoms even when they were taking nothing. So the symptoms didn't go away when they went to the empty bottle. So it's just a very interesting issue on how these patients perceive some of their problems. Is it real or not? It doesn't matter. The patient thinks it's real. It's up to us to decide what we can get them to tolerate. Most of the patients in these clinical trials, once they figured out that their symptoms happened whether they were taking the real drug or not, decided, shoot, I'm just going to take the statin. I think I need it, when the doctor talked to them. So we're going to go back to our patient again and decide what to do with her, right? Okay, so here's where she is. We don't really know yet about her situation with FH or not. She is intolerant to rosuvastatin 40. So what are you going to do for this high-risk patient to get her LDL down? So what's the next step?
And don't you think she's got FH?
Well, I think she probably does. But the question is it a single gene defect? So is it monogenetic? That would even be more important, because if she's monogenetic, she is extremely high risk from her lipid standpoint, because she's had it her entire life. Then you would start saying her TIA is not necessarily hypertension related. It could be vascular disease related to a genetic cause. A polygenic cause, yeah, it's still bad, but you'd like to know if it was monogenic.
So I take it you favor testing in a lot of people.
Yes, I think a patient should be given the option. There's reasonable cost to get a genetic test to determine what the issue is with the patient. It's also convincing them that they inherited the problem and that they may have cascade screening for family members or others. So it's important to know. So what would you do? I think you've all decided. If you haven't,
Get some few late voters coming in here.
yeah, a few late voters coming in. But the question is, what would you try to do? Well, what you'd like to do is try and see if you can talk her into getting on a statin, okay? So it would be, let's try a statin. Let's try a lower dose, okay? So we switched the statin, gave her a different name, so it's now atorvastatin, not Rosuva. And instead of 40, it's only 10. And guess what? She's tolerating it for 6 weeks after the discussion of how important it is for her to do it. And you see her LDL went down about 35% or so it's now down to about 130. Obviously she needs to be half of that to get her LDL to optimal levels. And so the next steps are, what would you do based on the expert consensus decision pathway? Well, you could certainly try ezetimibe, or you could try the fixed dose combination. That would get you 20 to 40% lowering, but she obviously needs at least another 50% lowering. So the question is, would you add ezetimibe or just go straight to a PCSK9 monoclonal antibody? She probably needs to take that 50 to 60% drop, and probably the monoclonal antibody would be what you would add. I would probably also, Scott, I think her doc tried to use icosapent ethyl because it's supposed to be used with maximally tolerated statin in patients with established heart disease, but it's 4 grams a day when you use it, not 1. You might want to sort of either decide not to use it and move to more intensive LDL lowering, and at least move one medicine away as you start adding new ones in. But I'd probably get rid of that EPA, either you increase the dose or you just discontinue it and move towards your intensive LDL lowering is the way I would look at it. All right, I think I'm done with my part. Now we get to the real good part.
We just
Scott.
had the good part. Thanks, Peter. That was a great overview.
Thanks.
And very typical case that we see.
Yeah.
Yeah. So let's talk about a second patient. This is a male who's 74, Gabriel. He's Mexican-American, living in Houston near Peter. He's had type 2 diabetes for about 12 years. His A1C is pretty good. It's 7.1%. But he has had some end-organ damage, has had a neuropathy from his diabetes of only 12 years, diagnosed for 12 years, obviously probably longer. He's had a myocardial infarction. He's had percutaneous revascularization 3 years ago. His ejection fraction is reduced because he's had heart failure now. And he's also got non-alcoholic fatty liver disease. So he's got sort of a triple whammy from all of this, right? Heart disease, diabetic complications, and liver disease. His blood pressure's good, 118/71. His LDL is 170. His potassium's fine. He's on a lot of medications. He has very good coverage, so he can afford anything that we want to prescribe for him, right? He's on a mineralocorticoid drug. He's on Entresto. He's on metformin. He's on an SGLT2 drug. He's on clopidogrel and aspirin, now 3 years out from his PCI, which is kind of interesting, isn't it? And he's on furosemide a bit, and despite being on an SGLT2, he still needs a diuretic, and he's on really high dose Atorva and Zetia at 10. And he comes in for a routine quarterly follow-up visit, and he's highly motivated to reduce the risk of another MI. I suspect Gabriel has a new grandchild, don't you think?
Yeah.
Yeah. So what are his risks, right? What makes him at high risk? Well, a lot of things can elevate risks in these patients. So having elevated triglycerides, great work by Mike Miller many years ago from some of the statin studies, showed that any triglyceride value of, say, greater than 140 or 150 is a risk enhancer. And certainly at 175, it's certainly an elevated risk. Paul Richter's work with high-sensitivity CRP has convinced us that a CRP of 2 or more is a risk marker. I remember at AHA many years ago, Paul showing data on this, and it has really stood for the test of time. Elevated lipoprotein A. How many of you see patients with an elevated lipoprotein A? I know Elliot does in the audience there, but many of you, yeah. So any lipoprotein A elevation above probably 50 is a risk enhancer, certainly higher than 125 really is. And an elevated ApoB, right? That tracks right along with LDL to go right there. So, and if he has peripheral arterial disease, so an ABI of less than 0.9. So by the new consensus statement, the guidelines, who's at very high risk? Let's go from high to very high risk. So it's patients who have had, 2 of these major events, right? Whether it's a recent ACS, a history of MI, a revascularization, PAD, claudication, or an ischemic stroke, or someone who's had 1 of these events and then 2 of these risk enhancers, like type 2 diabetes, heterozygous FH, an elevated lipoprotein panel despite aggressive therapy, et cetera. And I think if we look at Gabriel, we can see that he hits all of these, right? Peter showed this slide about FH. It's very common. We see a lot of it in our practice. I tell our fellows, if you see someone with an LDL of 200 or more, they've got FH until proven otherwise, right? Now, it could be an autosomal dominant dyslipidemia, but it's practically the same thing. They're at risk, and they have events, and so we need to treat it. Homozygous FH is quite rare, and most of us don't see that in our practices. We can do a lot to improve lipid control in the U.S., right, or frankly globally, whether it's adding second oral agents or 3 oral agents, or adding the monoclonal antibodies, or even inclisiran, a new small interfering RNA. Now, the important point about this slide that I want to just show you is if your patient's at very high risk, the target LDL is 55. And so to get there, it's going to take polypharmacy for dyslipidemia, right? There's just so few patients who can get there on a statin or statin plus Zetia alone. And so you're going to need to likely go to a monoclonal antibody or to inclisiran or to the combination of bempedoic acid with ezetimibe plus a statin, and then you still may need to have an injectable therapy. Now, how do the new therapies that target PCSK9 work? Well, this is one of the great stories in the last 20 years in lipids, isn't it, about these agents. What we know is that the protein PCSK9 is part of a recycling process for removing the LDL receptor from the liver. So anytime that LDL and PCSK9 bind together inside the LDL receptor on the liver surface, as that is then absorbed into the hepatocyte, there's a kill signal given to destroy that receptor. And if the LDL binds without PCSK9, that receptor is recycled back to the surface. So any therapy which lowers PCSK9, like the monoclonal antibodies, which basically bind almost all of it in plasma and eliminate almost all of it from circulation, you have an upregulation, so to speak, of the receptor on the liver surface because you're just constantly bringing those receptors back out. The body's producing new receptors, and the old receptors just continue back out to the surface. So by a surface area standpoint, you have more removal of LDL, and hence you lower LDL in plasma. Now, inclisiran is not a monoclonal antibody, but instead it's a small interfering RNA, and it binds to the ASGPR receptor on the hepatocyte through its GalNAc carbohydrate moiety on the tip of this 23 amino acid structure, which takes it right to the liver, and there it's brought in, and the 2 strands, the sense and antisense strand of the RNA, separate, and then the antisense strand works in the RISC complex, the RNA-inducing silencing complex, in the hepatocyte to block the transcription of the messenger RNA for PCSK9. So it reduces the synthesis of endogenous PCSK9 by 60 to 65%. So a little different than a monoclonal, which binds all circulating PCSK9 everywhere. The end result is about a 50% reduction in LDL from using inclisiran. So here's the mechanisms of action of what I've just described. Here you can see graphically what's happening with the monoclonals. They do an amazing job of binding PCSK9, and then the receptor comes right back out. And then here's an example of what's happening with inclisiran, how it's taken up by the ASGPR receptor on the surface of the liver because of the GalNAc carbohydrate attached to the tip of it, and that delivers the drug right to the organ of interest, right? It's really a breakthrough therapy, I think, and a concept, more than a breakthrough in therapy, but a breakthrough concept that you can target now appropriate organs with agents and drugs that will improve either function, improve longevity, or improve a disease state. And it's not just lipids that we see this with, it's also now with transthyretin amyloidosis. Now there is outcome data, or I should say there are outcome data, right? With the monoclonals. Two large outcome studies were done, the Fourier trial with evolocumab and the Odyssey outcomes trial with alirocumab. Both showed very robust reductions in LDL. Now, to get enrolled in these trials, which enrolled patients largely who were post-ACS, you had to be on maximally tolerated statins, whether it was 40 or 80 of atorva or 20 or 40 of Rasuva. So baseline lipids were reasonably well controlled, about 90 in this population of patients. Not ideal, not at 70, which was the target at the time of the enrollment for most of these patients, but pretty good at 90. And then with treatment with a monoclonal, you can see with evolocumab, they brought the mean LDL way down to under 40 milligrams per deciliter. And with alirocumab, it was brought down initially to about 40, 45 milligrams per deciliter, and then over time it sort of slipped back up into the low 50s and some of them into the upper 60s. But again, pretty robust reductions in LDL, about a 40 milligram to 50 milligram LDL delta or reduction with alirocumab, and even more with evolocumab, probably close to 60 milligrams of LDL reduction, or 59% reduction with evolocumab, 61% reduction with alirocumab. Now, how does inclisiran stack up against that? Well, this is data that we published in JACC a few years ago and presented at ACC a couple of years ago as a late-breaking trial. Inclisiran is given only twice a year, so it's an injection every 6 months, typically, with one exception, which is on the first year, a patient gets a 3-month booster dose. We saw a 52% or so reduction in Orion 10 in averaged LDL versus placebo at 510 days, and a mean reduction across the area under the curve reduction of similarly. And with Orion 11, about a 50% reduction in LDL at day 510, which was the co-primary endpoint of both of these trials. Now, Orion 10 enrolled patients with atherosclerotic cardiovascular disease, like both of our patients. Orion 11, 80% or so of the patients were ASCVD, and about 15 to 20% had risk factor equivalents, which is why the LDL values were a little different. This is a slide that I asked to put in from the Fourier analysis, which I think speaks volumes about why we should treat patients to very low LDL levels. And if you look at the LDL cholesterol 4 weeks after randomization in the Fourier trial, now these are all high risk or very high risk patients because they've had ACS, most of them have had revascularization, they've had elevated lipids, and as you know, about a third to 40% were diabetic and the same number with hypertension, okay? So very high risk. And what we saw, or what the investigators demonstrated, and we can see today from the publication, is that reducing the LDL to as low a value as possible was associated with lower event rates. So if you start at 4 weeks with an LDL that's, say, 4 millimoles per liter, or 4 times 40, 160, that's pretty high, a lot of event rates. But if you get it down to 0.2 or 0.3, so on target LDLs of 20 to 40, there was a 12% event rate in the primary endpoint, so a large reduction. So there was a bit of an inflection around an LDL of 70, which I'm not surprised because we saw that with Improve It, right? Going from 70 to 55 was about a 1% to 1.5% absolute risk reduction. And the secondary endpoint, it was almost a linear drop from 12% down to 8% by taking LDLs to previously uncharted territory or extremely low levels. Now, they followed this up with a presentation later at ESC and then a publication called the Fourier-Ole trial, which looked at maintaining LDL levels for 8 years. So this is the open label extension. That's how the OLE comes about. And you can see that patients who were on placebo in the Fourier trial who agreed to switch to open label treatment had very low reductions in LDL, mirroring those who had been on evolocumab since day 1. And you can see that they had extremely low event rates. Now, those who were on placebo initially and then got open label treatment had higher event rates than those who were on evolocumab the entire time, showing that the several years of time that they were on placebo did have an effect at raising their event rates to the extent that they had higher event rates despite then switching to treatment later on. So I think the lesson here is that if you're going to treat someone at very high risk to an extremely low LDL post-ACS, start it in hospital or at the time of hospital discharge. Don't wait 6 months. Don't give them 6 more months to prove that lifestyle and diet is just another natural history study of failed lipid management. Start them early because the events happen and they will see more reductions if they're treated more aggressively. And that's basically what I just showed you here. All right, and the long-term safety was present in those who were on this open label extension for a long period of time. Serious AEs, muscle-related events were extremely low. You can see that new onset diabetes did not go up. There was no additional new diabetic cases in those who were switched to open label extension. Hemorrhagic stroke rates were exceedingly low. Now, why is this important? Well, we've had a lot of concerns over the years that taking LDL to extremely low levels might raise one's stroke risks, and I think now we can see that those rates are just not there. It's just really an rarely encountered, if not extremely rarely encountered cardiovascular endpoint. So does treatment with a PCSK9 altering drug reduce 3-point MACE, which is death, reinfarction, and non-fatal stroke? And the answer is yes with the monoclonals. Well proven with the Odyssey outcomes and Fourier trial. You can see the average risk reductions are a little less than 2%, so the number needed to treat is higher than 50, but less than 90. And the relative risk reduction, depending on which trial you look at, ranges 14 to 20%. Now, with inclisiran, the answer is not yet. We don't have the data yet because the Orion 4 trial continues to enroll patients and will follow them for a fixed amount of time. So it will be several years before inclisiran has cardiovascular endpoint data. But we did publish a follow-up paper from our phase 3 lipid-lowering studies with inclisiran, showing that patients who were randomized in Orion 9, 10, or 11 to inclisiran versus placebo showed, or there was an association of fewer events, fewer major adverse cardiovascular events, which mirrors the MACE endpoints of large clinical trials. So about a 25 to 26% reduction in MACE associated with randomization to inclisiran. Now, these 3 trials were not powered for endpoint numbers. They were not designed to look at hard endpoints, but we did collect data from the case report forms. And I think this is a very interesting observation, reassuring us of the safety of this class of therapy, inclisiran, and I think further confirming that the LDL hypothesis is indeed correct, that lowering LDL reduces major adverse cardiovascular events. Now, Dr. Jones earlier showed data from another slide. This is a challenging one, which looks at the differences of how much we can lower non-HDL cholesterol, LDL cholesterol, and ApoB after treatment. You can see that there are robust reductions in LDL with evolocumab, alirocumab, and inclisiran, much more potent than with oral therapies, ezetimibe and bempedoic acid. Non-HDL cholesterol is lowered comparably across those therapies that are injectable and comparably across the oral therapies, but the injectables beat the orals every time. And then ApoB is also potently reduced if you're an ApoB advocate. There's also evidence now that targeting lipids with a PCSK9 may reduce coronary artery plaque. There's the Pac-Man AMI trial, the Glacoff trial, both of which showed some reductions in atheroma volume. Again, I don't put a lot of emphasis on this when I talk about these agents because I think the hard endpoints and the outcomes trials have much better data than what we're seeing with plaque, but at least the plaque is moving in the right direction in these studies. What are the most frequent side effects or adverse events with therapies? With alirocumab, injection site reactions were about 2% higher compared to placebo. The rates of influenza were maybe 1% higher. With evolocumab, you can see a slightly higher rate of nasopharyngitis and upper respiratory tract infections. Influenza, the same, 1% increase observed with alirocumab. Interestingly, back pain, hard to know whether that's related to the injection or whether it's just the population studied, and injection site reactions were about 5 to 6% between placebo and evolocumab. With inclisiran, injection site reactions were about 8%, comparable to what was seen with alirocumab, a little more than what was seen with evolocumab. Most of these are painless and just are pruritic and have a little bit of redness and they go away. We have not heard, at least to date in the patients that have been studied, that patients who had one injection site reaction gets another. And I can't speak for the monoclonals, but I suspect it's the same. Arthralgias were about the same, and we reported in one of our JACC papers and in the package insert a little higher rate of nasopharyngitis with inclisiran versus placebo, again, what was seen with the other PCSK9 agents. Now, the monoclonals require frequent administration. Most patients are taking them every 2 weeks. A few will take them once a month. It's a subcutaneous injection, so it's a shot every 2 weeks or 26 injections a year. And thankfully, the insurance market has now started covering these much better than they did at the time of launches of both of these products. Inclisiran is a very small subcutaneous injection. I describe it as akin to getting a flu shot. It's about 1.5 cc's, and it's given subcutaneously every 6 months, with the exception of the first year, a starter booster at 3 months after the initial coverage. And most of the major insurance providers in the U.S. are now covering it as well, and Medicare has very good coverage if you meet the appropriate label for using it. All right, so we'll go back to our case now. We have Gabriel, who's 12 years a diabetic. As you know, he's had several cardiac issues, a myocardial infarction, PCI with revascularization. He's got heart failure, HFrEF. He's got chronic kidney disease. He's got well-controlled hypertension. And despite being on all of the great and modern evidence-based therapies, his LDL remains at 170, and he's back to see you. So I think we all would agree that he needs to have a lower LDL. So what would be your next step for improving management of his dyslipidemia? Would you initiate a monoclonal with alirocumab or evolocumab? Would you talk to him about inclisiran? Would you refer to a lipid expert for maybe consideration of apheresis or other oral therapies, or would you leave him alone? Peter, how would you talk with this patient if he were coming to see you?
Well, it's amazing. He probably takes all of these pills. So the question is, an injectable would probably be reasonable for him, and he'd probably like to make it as uncomplicated as possible. So you have to discuss what would you like to do? Inject yourself, or come in every 6 months and we can give it to you here in the office. So, it depends on what the patient wants, but that's the shared decision making that's most important in this case. He needs some injection. The question is, which one is he going to do and accept and manage?
And I think the decision was made for him to switch out Atorva to Rasuva to maybe get an extra 5% or 6 milligrams per deciliter reduction in his LDL. And he opted to try inclisiran every 6 months just to try to simplify his life a little bit away from having to take an injection every 2 weeks. All right. Well, what about using 1 year later, he's back, and his LDL is now 80. So he's gotten down from that high LDL down to 80. He's compliant with all of his medications. What about adding bempedoic acid and icosapent-ethyl? Is this the patient that we would want to do that to? And he's also tired of driving in. I guess he lives about an hour and a half from the office, and he's asking, is there a better place to get inclisiran? And can he get it closer to home? And Peter, I think that's one option we have for patients is they can be referred to an infusion center, right?
Correct.
And you can find that online. It's lecviolocator.com, I think. I use that for patients who I want to treat with inclisiran. And I've found several in the region. So What about imipamidonic and icosapent ethyl? All right. What about that? Would you do that in this guy to get him down further, or would you just switch him to evolocumab?
No, I think he does need a definite further reduction. The question is how much more complicated do you want to make this? And if you're looking at trying to get his LDL down even lower than 80, you could offer, again, with his complicated medicine regimen, switch the ezetimibe to a fixed dose combination with bempedoic acid. So you switch one pill out for another. You might get another 20% lowering in his LDL. You get him below 70 milligrams per deciliter, still staying with no change in his pill count. That would work. You know, trying to use icosapent ethyl, you know, and these are one of the questions we got asked here about, you know, what does it really do? Well, it lowers cardiovascular events in high-risk patients who are on maximally tolerated statin.
So he's
but it
definitely
doesn't do it with lipid.
He's somebody I would put on it, but not for the lipid effect.
But it wouldn't be for a lipid effect, so it'd be something you'd have to discuss as separate from the lipid effect, but you want to optimally treat his LDL first, and then you could discuss about using it. But the mechanism of action is still unclear, but it's probably not through altering lipoproteins per se, but it's probably through anti-inflammatory and phospholipids and a variety of other mechanisms that are not easy for us to actually test for and follow and understand. But the first goal would be to see if he's willing to make this medication switch to get lower on his LDL, I think.
And I think it's important to point out with inclisiran, we put this slide in, with alirocumab and evolocumab, you give a prescription, right? Patients go to the pharmacy, they have coverage or they don't, they take it home, they give it. With Leqvio or inclisiran, you have to give it in a healthcare provider office. So you either administer it at your office, and you can buy the drug from Novartis or one of the wholesalers that they use, and buy it, and you have your buy and bill where you bill for it and then get paid, or you can refer them to an injection or infusion center. And I know in some of the patients I've heard stories about, those on Medicare, the out-of-pocket costs are pretty low if they have a good secondary insurance along with Medicare. Many of them, for example, in our Scottsdale, Arizona region, I understand are paying about $400 a year out of pocket for the medication, which is a pretty low copay out of pocket. Or you can use a specialty pharmacy within office administration. So those are all three options. But inclisiran or Leqvio is very different than evolocumab and alirocumab because you just can't do a prescription. It takes a little bit of an effort to get it going, but it's a very easy process. How about other questions? Let's stop here and do some other questions.
Yeah, there are some questions from our audience, and some of you are online and some here in the room. But it's come up in at least four of the questions relate to what you explained briefly as a risk-enhancing factor, which is Lp(a). Neither one of our patients had Lp(a) values. Do you measure Lp(a) on all your patients or just your high-risk patients, or what's your strategy?
Oh, that's a great question. I get this question a lot when I speak at meetings. I'm sure all of you get this too in your practice. What I do is if I have a patient who's on a decent dose of a statin, 20 or 40 of Rasuva or 40 or 80 of Atorva, and their LDL isn't dropping, I immediately measure a lipoprotein A because many of those patients will have elevated lipoprotein A, and it's just keeping that LDL from dropping like it should. If I have someone who's young or has a family history where everybody has heart disease, everybody's had revascularization or PAD or some issue, then I'll measure lipoprotein A. So I don't measure it in all, but probably in a third to a half of the patients I tend to order it because what we'll discover is that more people have elevated lipoproteinases than we ever imagined. And I have to smile at this because when my own mother had a myocardial infarction, her physician or internist measured a lipoprotein A and hers was elevated. So I immediately went and measured mine, and thankfully mine was not. But it's an important risk enhancer, and I think we're on the threshold, frankly, of knowing if treating an elevated lipoprotein A can reduce risks even further than we have originally thought. And we'll have those answers in just a few years with the studies.
Yeah, I mean, it's pretty easy to measure. So I think in patients that you're looking at high risk or very high risk or premature family history, you're trying to look at a reason for why they may have that premature family history. I think measuring under those circumstances, it's very reasonable to do. The question is if it's elevated, the patient says, okay, now what? Well, right now we don't know what. But hopefully we'll get the answer because there are therapies that are specifically, and we just had an example on Saturday of a PCSK9 siRNA presented, olpasiran, that gives 90% lowering in LPA. I mean, it's just astounding what we have available. So for some patients, If it proves that it works independently, then that would be something we can offer. But right now, it's a risk-enhancing factor. Maybe makes you want to lower LDL as much as possible. Of course, the PCSK9 inhibitors do lower LPA 20% or so, 25%. It's a little bit of a help, maybe incremental benefit. We don't know for sure. But that's the only thing that really effectively lowers it. Niacin can do it, but we don't use niacin because of adverse events outweigh the benefits. So
I would add a couple of thoughts to that because I was a cardiac intensivist for 2 decades before moving away from that part of cardiology. Lipoprotein A elevates Pi1, which makes you more prothrombotic. So I think you need to consider dual antiplatelet therapy in patients who have really high lipoprotein A levels because they're going to have more thrombotic events, right? And I also tend to use ACE inhibitors over ARBs because ACE inhibitors lower Pi1, which is how they provide such a great reduction in recurrent myocardial infarction. If you look back at the CARE trial, I think, and others, Mark Pfeffer pointed out to me many years ago that Pi1 is the mechanism, and so lipoprotein A modulates that. So I put them on ACE inhibitors if they have a hypertension to counter that. I think now you get a double benefit from any of the PCSK9 therapies, whether it's Repatha, which is evolocumab, alirocumab, or Leqvio with inclisiran, because they all lower lipoprotein A and take LDL to extremely low levels, and that's really the winning combination right now, I think, is to use a PCSK9 drug.
yeah, and the question is, should you measure Lp(a) in everybody once in their life? Well, yeah, it's genetically determined, and it rarely changes. It's never going to change. So at some point, we'll get there, only if we have a documented way to
I suspect it's going to be added to the lipid profile eventually.
I think so. I really think so. One of the other questions that came out about, I brought it up about icosapent ethyl was, does anybody really ever use it under what circumstances? And I think yes, for severe hypertriglyceridemia, it's indicated for that to prevent pancreatitis. The question is, do you just give it to everybody on maximally tolerated statin regardless of their LDL? I don't know. It's not easy to take. It's 4 capsules a day, and it's not inexpensive. So it's a shared decision making. There is outcomes benefit, but I don't think we would do it in place of, for instance, like our patient Ann, where she couldn't tolerate a statin. I'll just give her IPE, instead. I'm not sure that's what the Reduce It trial showed us. It wasn't in statin intolerant patients. It was on maximally tolerated statin with an LDL of 70. So.
Who were post-MI.
Yeah.
And that's tend to where I restricted use.
You just have to be careful about how you use that. I think there was a question about genetic testing for FH, like in my patient. Isn't a physical exam enough? Well, actually, there is the Simon Broom and the Dutch Lipid Clinic Network that you can just do physical exam looking for tendon xanthomas, the level of their LDL cholesterol, and family history, and you can get a definite history. Well, yeah, but the monogenetics causes is important not just for the patient because of lifetime exposure of LDL from the moment they were born, but it's also important for cascade screening. I mean, there can be family members who could inherit the same monogenetic gene but not get xanthomas, and they may not have them early in life. And so knowing with genetic testing, it may influence your decision to do cascade screening. But I do think it's reasonable to do, and if you're fortunate enough to find a single gene, great. Most patients are not going to be just single genes. Some of them actually are, the higher the LDL, the more likely they are what's called compound heterozygotes. They have a couple of genes, and that causes their LDL to be 300 or 400 instead of 200. And then, of course, the homozygotes are pretty clear because they come in at over 500 anyway. But you might want to know why they're a homozygote. So genetic testing can sometimes help. We're about running out of time. There was one other question about do you use any supplements to help lower LDL, phytosterols or anything else? Do you think that those are helpful in some patients aside from a healthy diet, high fiber or so forth diets? Use any supplements?
I don't recommend them. I say to patients, it's your money in your life. You can choose to spend your money on those if you wish, but I don't endorse them and don't recommend them. I think there's a lot of, we see a lot of challenges in our patient population of people taking all kinds of supplements who have minor coagulopathies and other things from the off-target effects of the supplements, and I just don't routinely recommend them, and I discourage them, but it's fighting an uphill battle, so I can't win that.
Well, sometimes that's for the statin intolerant patients. They're looking for other things too to help lower their LDL, and they'll go to the stuff. And I think here at the AHA meeting, I think again it was presented on Saturday, they were looking at supplements and their effects on LDL cholesterol. I don't know whether you saw that. Very little effect of any of the supplements they looked at. Even red yeast rice only lowered LDL about 10 or 15% with an over-the-counter red yeast rice. So, the bottom line is work with your statin intolerant patient as much as you can with approved and established medications, including attempts at taking statins. And I know some of you have probably done once a week statins, Monday, Wednesday, Friday statins. Whatever you can get a patient to tolerate, that's a good start. And then you move on with shared decision making on your other therapies to get their LDL as low as possible.
Yeah, we recommend, starting at rosuvastatin 5 if you have statin intolerance once a week, and try to work up to 2 to 3 times a week.
Correct.
It's amazing how much LDL you can lower with a single dose of rosuvastatin on Mondays.
It's amazing. It is.
Well, it's been a great audience, great question.
It has. Great.
And,
Guys, thank you so much for coming out early this morning. I hope you've enjoyed the AHA meeting so far this weekend. And we got a few more hours today, but it's great to see some familiar faces. Thank you so much for being here, and we'll see you all at another meeting, okay? Thank you.